Our next speaker is Dr. Giovanni Grasso from Italy. He will talk about the hybrid surgery.
Hello, everybody.
Hi.
It's a pleasure to be with you today. I have been asked to talk about hybrid surgery for cervical disc disease. Today, I'm not in the hospital, unfortunately, because our offices are being sanitized due to the COVID. So I will share with you a more conceptual presentation than practical presentation than Richard did before. So I'll start.
I think we are ready for Giovanni's presentation.
Okay.
We can continue with Giovanni.
Okay, thank you. Now I fixed the problem. So let's start with a more relaxing presentation than Richard did before. Okay. Cervical radiculopathy and myelopathy are common pathologies in adult patients, and they are very important cases of loss of productivity. And we do know that surgical options for treat this pathology include posterior decompression and, sorry, we have here and fusion, anterior cervical discectomy fusion, ACDF, and cervical disc arthroplasty, CDA. We know that ACDF to date is the most accepted treatment since it offers satisfactory clinical results, since it is effective in terms of resolving symptoms, improving nerve function, and restoring also the physiological curvature of the cervical spine. However, in the past, it has been pointed out that fusion may alter the biomechanics of the spine, which may lead to the acceleration of the adjacent segment degeneration. And all these concerns have stimulated the blossom the search for motion preservation procedure, such as the artificial cervical disc arthroplasty. Now we know that CDA is safe and has been proven to be beneficial in terms of preserving motion of the cervical spine and reducing also the rate of adjacent level degeneration. So we know, based on FDA reports, there are some contraindications for CDA. Most important are underlined like ankylosing spondylitis or skeletal hyperostosis or spondylosis with the bridging osteophytes, ossification of the posterior longitudinal ligament, severe osteoporosis or osteopenia, and of course, instability on dynamic radiograph. Indication of ACDF versus CDA. So this slide shows you that ACDF can be proposed in every case, less the CDA, especially when you see there are some instability or poor bone quality. This is one example of the CDA, and Salman asked me to provide with some questions during the presentation. So this is one of these. So what do you think is right as contraindication for CDA? Severe osteoporosis, long neck, level C3, C4, or level C4, C5? So the answer is up to you.
Almost everybody answered with osteoporosis.
Osteoporosis. Yes, this is the right question. So what we have to do when we are facing with patient having a multilevel cervical disc disease? In the recent years, hybrid surgery that incorporate ACDF and CDA at different levels has been shown to be a possible solution. The purpose of this technique is to mix the advantages of both techniques in terms of vertebral stability and spine motion preservation. So as I told you before, I don't have here too much slides, for example, to show you, but I would very pleasantly showing you my personal experience. From 2009 to 2015, I collected prospectively 15 consecutive patients who underwent hybrid surgery. And this patient have been compared with the same number of ACDF and CDA patients. Inclusion criteria were, of course, degenerative disease with radiculopathy or myeloradiculopathy. And exclusion criteria were one or more than 2 vertebrae requiring treatment, so 2 levels were the target, prior spine surgery, the OPPL, of course. I want to go back, okay. Severe facet arthritis, lack of motion or stability at the level of surgery, fracture, tumor, and so on. Some preoperative features. Presence of motion on preoperative dynamic X-ray is fundamental to choose the CDA approach. If no motion at the level that you are going to operate is observed, of course, ACDF is the technique that must be offered. In case of radiographic scenes of instability, ACDF, of course, must be used. So patients receiving CDA or hybrid surgery, if both or at least one level meet the criteria for arthroplasty. In hybrid surgery cases, CDA was performed at a mobile and non-spondylotic segment. The technique I use usually is a right standard side approach. For a CDF, usually I use in the RYC cages that you can see here. For the CDF, for the arthroplasty, usually I use in the past the ProDisc C, right now the Mobi C. So this video showing you this very simple procedure that is positioning the arthroplasty after performed that if you see down the ACDF. So some suggestions for pure CDA and hybrid surgery. Patient selection is important, very important, is fundamental, I would say. Similar to a CDF, but not the same. We need intra-op fluoroscopy to verify the midline and the proper sites of the prosthesis. Posterior release, resection of the posterior ligament is important because need to mobilize the disc space in symmetric fashion. More attention to details and symmetry with CDA versus ACDF. Minimize the drilling and use a proper size of the prosthesis, never overstuff. So this is some cases with a CDF, double CDA, and hybrid surgery. So the second question is, what's wrong? Feature for pure CDA and hybrid. Proper patient selection, no fluoroscopy is necessary. Midline identification, not drilling. What's wrong among these questions? Does we have an answer?
The majority is saying 2.
Majority say too, and of course is important. The use of fluoroscopy is very important because it can help you in finding the midline perfectly, and also in using the proper size of the prothesis. So of course this is the right answer. So, and other cases showed here the post-op for a patient with the neutral and the extension flexion working, looking at the system works. Contraindication to CDA, what's wrong? C4, C5, C6 level, instability on static XRI, posterior facet arthrosis, or C3, C4.
The majority saying 2.
2, yes. I mean, there is 1, 3.
It's 3. Yeah, it's 3. Contraindication to CDA. Yeah, you know, this was a particular question, instability on static. But we do know that instability is achieved by dynamic X-ray, non-static X-ray. Okay, so the right answer is the 3. So the posterior facet arthrosis. So for the study that I showed before, for the series that I showed you before, I collected all demographic data, intraoperative details, postoperative details, radiological findings, and complication. All the patients have been followed at 1, 6 months and every year for the duration of the study. These are all the outcomes measures that are used for this cohort of patients. And of course, the range of motion have been also evaluated, also the discrete and the degenerative changes. So some of the results, all the patients had a minimum of 5 years follow-up, and we did not have differences between patients with myelopathy. Comparable number of patients presented with myelopathy preoperatively. In each group, all the patients had 2-level surgery, and the functional score were similar in all the groups. So here the results: the median duration of operation was significantly shorter for ACDF. The length of hospitalization did not show differences among the groups. What is very strange is that the hybrid surgery group returned faster to work compared to the other group. I don't have an answer for these findings, but it was we observed. And all the outcome measures improved in all the groups. And range of motion increased in CDA and hybrid surgery as compared with ACDF, and the mean disc8 was significantly restored in all the groups. This is one case, 45 years old woman with too long history weakness in both hands with left prevalence. This is the MRI showing discopathy in C5, C6, and C7. This is the post-op for these patients with restoring all the issue we investigated before the surgery. So main features are the duration surgery was significantly shorter for ACDF. All the outcomes measures improved in all the patients. The cervical range of motion increased significantly in CDA and HS groups. The mean disc8 was restored after surgery in all the groups, and the hybrid surgeries group returned faster to work than the other groups. So when selecting patients for hybrid surgery, some factor should be considered. Degenerative disease must be, of course, strictly considered. Spondylotic spine is often associated with the multiple level disease, and not only the affected levels may meet the criteria for CDA. So hybrid surgery can be an alternative to a multilevel ACDF or multilevel CDA. The main role of this kind of surgery will lie in restoring or maintaining motion where appropriate, or promoting bone fusion when indicated by the extent of the degenerative changes or hypermobility. Hybrid surgery should provide a balance between both ACDF and CDA. This is some series published so far in the literature. And also, we recently looked at the quality of life of these patients. And in this series, we found that patients treated by hybrid surgery improved, also looking at the Japanese orthopedic score. For the NDA, the same. For the VAS neck, the same. VAS arm and legs, arm and neck and arm. And also for the SF 36, we have improvement, both for the physical subscore and also for the mental subscore. So, feature for pure CDA and in hybrid surgery. What's wrong? Proper patient selection, fluoroscopy is necessary, midline identification, always oversized measures. Characteristic for pure CDA or hybrid. What's wrong?
Most answers are 4.
And they are right, because this is the right answer. Yeah. So I showed you my experience with the hybrid surgery construct that I found to be safe and effective, even to achieve the compression, so to achieve the job to decompress the neural structure, but also in offering a good outcome to the patient. Of course, further study are needed to verify the results, but it seems that right now in literature, a bunch of studies are blossoming about this issue, and they are following, seems they are following this line. So that's all. I was very fast, I think.
Okay. Thank you. Really, very controversial subject, and difficult subject, actually. I want to ask you, how do you select the fusion level and artificial disc level? What are the criteria for you?
The criteria are those I showed you before. So where the level is more mobile than the other, then I choose to put an arthroplasty. Otherwise, if there is instability or the segment is not so mobile, I use the ACDF.
Okay. There are some questions. The last one is that multiple studies showed no difference in long-term outcome. What about cost effectiveness?
There is no study about cost effectiveness for hybrid surgery, but there are studies comparing ACDF and CDA, and they are equal so far. We have a very recent publication in World Neurosurgery dealing with this issue. So far, there are no differences among CDA and ACDF. So I could assume that also hybrid surgery can follow this line.
You have mentioned that in choosing the patients for CDA, if there is a preoperative neck pain, you don't think about CDA. Am I right?
No, I didn't say this. Maybe your question would be if the patient complains also along with the neurological deficit, also the neck pain, if arthroplasty can be used. Yes, of course. I have experience with this, and the post-op are always very nice. But the problem in reducing and solving the problem of the neck pain is the relying in choosing the exact size of the processes. Otherwise, you have if the process is oversized, the neck pain will worse, not improve.
Will be worse.
Yeah.
Okay. And the question is, Dr. Mohammed is asking, what is the incidence of neck pain after disc replacement?
In general, in the literature is about 10–15%, but it depends, as I told you, the technique used and all the all the details that you use when you put a disc. So what you have to consider is the right size and the right position of the prosthesis in order to respect also the so-called concept of center of the rotation.
Okay. What about if there is a posterior, there are posterior osteophytes? So do you consider as a CDA?
No,
You don't?
never. No, never. Because you have to remove the osteophyte, and then you start stimulating the bone growth. So this can be a problem for the arthroplasty. So for thoracotopic ossification, right?
Yeah, right. Another one is Nasiru is asking, in hybrid, is CDA above or below, and why?
It depends. If you have a
both.
Sorry?
It may be both.
It may be both. Yes, of course. But of course, I don't perform an CDA in 6/7, of course, because usually this segment is not so mobile.
Okay. Salman, do you have any comments or questions?
Yeah, I think it's a very good presentation, and I think it's good to see a different aspect of doing things. And many people have tried various hybrid surgeries and shown different results. I think it was a very good lecture. Khalid Ashore wants to ask a question. Khalid, please introduce yourself and where you're from, and then ask your question.
Yes, thank you very much for this nice lecture. This is me, Khalid Ashore. I'm Egyptian, working in Saudi Arabia. I'm asking regarding this hybrid surgery, 2 questions, please. Number one, when you said that in cases with little or limited movement at the level, ACDF is better than the CDA. So my question is why, if we can improve the mobility at that level? The second question, when we choose the size of the CDA, so what's the reference to choose the proper size? Is it the adjacent normal level or something else? Thank you.
Very good question. So for the first question, I would say if some mobile is seen during the dynamics study, I can use also the CDA. So this is not a problem. And because also CDA can improve the mobility at that level. So for the second question was how to choose. In general, what I have to do is try to match the length of each disc of the cervical spine, and usually before surgery. And usually I try to define which could be the maximum size of the prosthesis that I have that I have to use.
We have another question.
To add in also further, there is also a sensibility during the surgery. So you don't have to distract too much to put the prosthesis, okay? So this is something that you can find also with experience.
Okay, we have Tunki Omar who wants to ask a question. Please state where you're from and then ask your question. Hello, are we there? I think we disappeared on us. Okay. Let's see if I can unmute again.
There is one question, but I have difficulty in understanding the question. Dr. Domenico Catapano is asking, do we have to avoid plate drilling in ACD? CDA, I think.
Plating, you mean?
Plating. Actually, probably the question is that if you are doing fusion one level, CDA on the other level, do we ever place a plate on the fusion level?
Sometimes I did in the past, but so far I use the self-locking cages, so I don't need to put plating.
Okay. Another question is, what do you mean by oversize? Should we restore the disc height or not?
I told you the oversize of the prosthesis of the cage or the cage is a matter of discussion and must be evaluated patient by patient. Must be careful with oversize prosthesis or cage because neck pain is not only the problem that you can find following the surgery. There will be also radicular problem. So I never exceed with the sides of the prosthesis of the cage. I try to be to stay in a medium size.
Mm-hmm. Okay, I think we answered most of the questions. I thank Giovanni for very nice, very interesting lecture, and we are finishing our webinar here now.
Okay,
Thank you very much.
What do you have for tomorrow and day after? So tomorrow we have IFNE and WFNS endoscopy committee weekend update on craniopharyngioma. So 3 different versions of endoscopic removal of craniopharyngiomas. You have Sergey from Russia and Luigi from Italy. And again, Pepe from Italy as well. And Chandrasekhar Devpujari is going to discuss a case. And that is for tomorrow for IFNE WFNS endoscopy committee. On Sunday, we have Sunday with the future of neurosurgery. So we have these beautiful ladies, neurosurgeons from all over the world. And of those, we have Zarina from Pennsylvania. We have Saud Bakshi, who's the chairman of the Women in Neurosurgery Committee for WFNS. Noor used to be our medical officer. Now he's a resident in UK. Maya Babu from Mass General Hospital and Anila Darbar from Pakistan. And we have Abida Shah from Mumbai. And we have, if you go down a bit, and we have Sandy Lam and Najia, who are going to be discussing various things about what they've achieved over time and their specific scientific lectures, and then discussion to follow this. Ahmad, have you got something else, or is that it? On Monday, I think we have Richard Asakar. Sorry, not Richard Asakar. We have Rick Fessler. I think so. So what we have is, on Monday, we have Rick Fessler and Maurizio, our friend, and Mehmet, you are the moderator again. So, which is going to be fun. This complex surgery of the cervical spine, and Maurizio also wants to talk about complex cervical anterior posterior surgery instead of FLIF and TLIF. And then on Wednesday, and we carry on from there. So we don't need to go into detail. Yeah, that's okay. Thank you, Mehmet. Thank you,
Thank you so much.
And I can see.
Thank you all the participants for coming, and thank you, Giovanni and Richard Asakar.
Thank you very much. Thank you for the invitation. I hope to see you soon.
Sure.